Hi everyone. This week I am stepping very far out of my comfort zone and I am making a video to accompany my blog as my visual aid. So this week's module we're discussing workflow in terms of medication administration. I'm just going to briefly introduce myself and where I work and then go through how I start my day and how that determines how my medication process is going to flow. So my name is James-Jamieson. I work at Belleville Hospital on the acute medical floor. I used to work at Oakville Hospital, which was quite a bit larger. We had a lot of we had like multiple acute wings. I think we had 4 of them that focused on a certain system of the body. So we had a cardiology acute care, we had a respiratory acute care, gastrointestinal, which is where I worked for 5 years. And then they had an oncology acute medical wing as well. In Belleville, we're a little bit smaller. We don't have that. We have 2 acute units, one for geriatrics, and the second one is for anybody between, I think it's the age of 18 and 60. So we see the acute, younger kind of adult age group. How I start my day. I always start my day by assessing my patients. So I look at them from the computer aspect and on the paper aspect, and I determine who I think is going to be my most acute. I'm going to start there. I'm going to work my way to my most stable. I then go to their room. I introduce myself. I say hello. I take their vitals and I do their physical assessment. I do both. After that, if everything's fine, they look stable, I go ahead and I administer their medications and everything is fine. And in this case, I am kind of following a very linear flow that was talked about in the module in regards to CPOE, so computer physician order entry. They suggest that it goes from a physician's order to a pharmacist for approval, to the unit clerk to transcribe, and then to the nurse to administer to the patient. So on a morning where all my patients are stable and they're great and nothing extra is needed, everybody's well taken care of, they're in therapeutic effect, that is a very common way to do it. However, many times that's not the case. It's an acute wing, so people are changing and they change quickly. So many times I'll go into a room and the blood pressure is through the roof. Say their blood pressure is 185 and it's over 93. And I go and I look at their medications and they have a whole whack of stuff that's going to affect blood pressure. They have some Lasix for their lungs, so they have CHF, let's say. And they have some nebulizers, PRN, and they have some BP medications. They're on some pulse medications. They have a whole whack of stuff. So I'm going to give what's appropriate. I'm going to give them the medications. I'm going to reassess them an hour post-med. And their blood pressure is now 144 over 73. And although that's still technically high blood pressure, it's much safer than the range that we were in. We're happy. Nothing extra is really needed. You might relay this trend to the physician in case they want to up any doses or whatnot, but we're happy. But say I go into the room and their blood pressure is 180 over 90 still. We're going to call the physician. We're going to give them our findings. We're going to say what we've done. In this situation, the nurse is actually initiating a new medication because it's very likely that the patient or that the physician is going to order another blood pressure medication, just a one-time dose perhaps, or maybe they're going to up the current ones. But regardless, it was actually the nurse who initiated this through their assessment to the physician. And then again, actually rolling with that, we might not go to the pharmacy next. We might just go pull that drug right away from the EDU or the dispensing unit that you have within your hospital, and we're going to give it. The pharmacy will see it later, but it's on the chart, so it works. But in that case, we went from the nurse to the doctor to the nurse again to the pharmacist after. And then the unit clerk to transcribe, sorry. So yeah, as you see, that was definitely not a linear flow at all. Other times it might be the patient that calls. If a patient's in pain, they might call you and say, hey, I'm an 8 out of 10 pain. You check their medication, they only have Tylenol and it's, they got it 1 hour ago and it wasn't effective. So you might call the physician for that and ask them for something different. So in that case, it went from the patient to the nurse to the physician and so on. Another situation would be a palliative patient if they can't speak for themselves. I think doing the assessment there would be very important because, again, that's not going to come from the patient. And unless if you tell the doctor, they might not up anything, but it's your job as a nurse to do your assessment and relay that information to the doctor to give this person appropriate care. But yeah, another way of initiating it would be through pharmacy. So we don't do this at Belleville, but I did see this a lot in my old hospital, where the pharmacist would actually go down to emerge. As soon as they heard that a patient was being admitted, they'd go down to emerge and either verbally organize their medications, see what they're on, interview them, and come up with a med list, dose, time, whatever. If the patient was not with it, or if they were confused, they would just go onto their computer and they would see if there was actually a previous admission, and they would look at their drugs from there. So in that situation, it's actually the pharmacy that's printing off a med rec, and then they put it on the chart for the physician to see. So the pharmacy is actually initiating it then. So yeah, it's ever changing. But yeah, it would be nice if it was always a linear flow, and maybe it is some places, I'm not sure. But in an acute care setting, my hospital is definitely not. Yeah, working with very vulnerable patients who are very, very ill, they change very quickly, and that means that medications are always being kind of tweaked or initiated or discontinued and what have you. Anyways, if anybody watches this video, I would love it if you did one back. So I can hear a little bit about how your process works, especially if you're not in an acute care setting. I would love to hear more about long-term or even community. If you work in community, I think that'd be awesome to hear what you do, because I have no information at all on how that process works. Anyways, thanks for listening, guys. Have a good week.